Maybe another 2 seconds more. Good evening, friends. Welcome to the webinar series of Indian Arthroplasty Association. This is the 29th webinar of the Indian Arthroplasty Association. We are happy that today we have many stalwarts with us, including Dr. Pachore, Dr. Amjad from Bangladesh. Indian Arthroplasty Association is having presently the membership of over 800 now, with the constant efforts of our very active secretary, Dr. N. Rajkumar. The history of Indian arthroplasty, as we all know, started with Dr. Dholakia, Dr. Mani from Delhi. Many other people have participated in progression of this academic association. Dr. Chitranjan Ranawat has a big contribution in India in developing and supporting us and teaching us the art of arthroplasty. Dr. Sancheti, Dr. Lord, these are 2-3 names that I would like to mention. Dr. Pachore, who is with us today, has been very, very active member of the Indian Arthroplasty Association. And our friend from Chandigarh has been a very, very active member, and he's the one who supported us in restarting this Indian Arthroplasty Association. That is what we see in today's present form. Monthly, we have been having the webinars every Thursday. They started during the COVID time in the presidentship of Dr. Shubhranshu Mohanty. And we have had so far, this is the 29th webinar today. And one webinar we had with the VIROC. This was the very, very well attended. Today's webinar is on periprosthetic fractures. The convener is with us, Dr. Rakesh Rajput from Kolkata. Our much awaited meeting at Coimbatore annual conference is on October 7th, 8th, and 9th. Today's webinar is on periprosthetic fractures around the hip. We have the many speakers. Dr. Mehul Acharya, for some reason, will not be attending this webinar. Dr. Pachore will be taking up his lecture. Our friend from Chennai, Dr. Vijay Bose, Sumit Hazra from Kolkata, Dr. Mohanty from Bombay, Kalaivanan, Rakesh Rajput, myself, Dr. Pachore again presenting a case, and our president of Indian Orthopedic Association, Dr. Ramesh Singh, will be presenting a very interesting case. Friends, I'll request all the orthopedic surgeons who are yet not the members of Indian Arthroplasty Association to become the member just going to our website or writing to us, myself or Dr. Rajkumar, and become the member and be part of this ongoing academic programs, which we are very, very proud and very happy to include as many friends as possible in our academic meetings. I'll request Dr. Rakesh Rajput to start the convening the meeting and give a short introduction. Thank you, everyone. Rakesh, please.
Sir, you are muted.
You have to.
Yeah, sorry. There was too much of things going on. Actually, my hospital is celebrating Doctor's Day also today.
It's a good day.
So there's a lot of noise in the background, but I've come peeled off. So I think this is our 29th webinar. And the topic which I chose was the periprosthetic fractures around the hip. We've already done one periprosthetic fractures around the knee, and I thought this is actually even a more important subject. And I think I wanted to choose predominantly our own Indian speakers actually for these, because I think the Indian doctors have made a huge progress. And I can't really think of two better persons than Pachore and Dr. Vijay Bose. So Dr. Pachore has come in at the last minute and very kindly agreed to do this topic. He doesn't need any introduction. I mean, he's one of the forefathers of our arthroplasty in India. And Vijay is a current father of our Indian arthroplasty. He also doesn't need any introduction. I'll also want to thank Sunit Hajra, who is very young and upcoming surgeon from Calcutta. Dr. Mohanty, who's been our past president. Kalavanan, who's again a very up and rising surgeon from Chennai. Our own president, Dr. Sharma. And Dr. Ramesh Sen, who is current the IAA president. He will try to join us a bit later. So I think without waiting anymore, I'd just like to say that what we really want to learn from today's webinar is to just have a brief idea about what sort of incidents we have. Do we have a running classification? And if there is any limitation to these classifications? And once we've classified, how do we go about treating these fractures? And are there any other modern methods of treating these fractures which have evolved just now? So friends, it's a definition, if you really look at it, it's very confusing in the literature. So principally, if you have any device and if you have a fracture around it, it's actually called periprosthetic fractures. Not necessarily it has to actually have a hip or a knee joint or a shoulder joint around it. The global incidence is rising because the primary surgeries are actually rising in huge numbers and people are living older. And as you grow older, there are other things which come into play and you get these fractures. So if you look at the incidence, if you look at the primary hip replacement incidence, it is still low, but gradually I think it is rising because we are doing a lot of difficult cases which we didn't tackle in the beginning. So 0.1 to 1.8% in the hip, 0.3 to 5.5% in the knees. The reason the knee looks a bit more because we do get a lot of subtle fractures around the condyles or around the plateaus, which we don't actually have too much of difficulties. So we don't seem to actually take notice, but there are fractures happening during the surgeries. And shoulder, of course, is a very difficult surgery to do, and that's why the fractures incidents are more. If you are a female, if you are rheumatoid, if you already have an osteolytic lesions from your primary replacements, and if you have advancing age along with osteopenia, you are very likely to get these fractures. The reason we want to talk about a bit more is one thing, which is about mortality. THR, we really don't consider mortality as a huge factor which limits our surgery. But once we have had a periprosthetic fracture, the mortality is almost like a hip fracture. So I don't think you need to talk about like a THR when you talk about mortality, but you need to talk about a fractured neck femur to these patients when you talk about mortality is that high. And the trouble is when you try to come and about fix these fractures, there are a lot of difficulties. You may have stems which will have problems. You may have rods which have already been inside. You may have prosthesis itself which may cause difficulty either with putting screws or even putting cables. Also, the healing may be impaired right from because of the endosteal ischemia or because of the fracture itself. Now compounded by osteolysis, osteoporosis, and implant motion, you have a nightmare scenario. We do have a classification which we followed for quite some time, the Vancouver classification, which took the patient factors, implant stability, and surrounding bone stock. But then we've had a newer classifications, which has come by the Duncan, Haddad, the Parka group, which is also taken up by the AO group now. And the goal of treatment, which actually remain with all other fracture fixations, will be you need to fix as long as possible. You need to provide supplementary fixations without damaging the blood supply. So that's the caveat. You need to provide as much fixation as possible without damaging the blood supply. So we still are looking at the biological ways of stable fixations. And we need to find some other newer methods if possible. And let's see whether those are going to be discussed here. So without wasting any more time, I'll request Dr. Pachore to come and give his talk on the classification of the periprosthetic fractures. Dr. Pachore? Sir, आप mute हैं.
Yes, I will do it.
Yeah, okay.
Okay.
Yes.
It's just coming, sir. Yeah.
Are you able to see, Rakesh?
Sir, I'm able to see, but I think we again have to go back to the display setting, the middle button on top.
Okay.
And just choose the duplicate slide.
That's okay. Now it's okay?
Yeah, now okay, sir.
It's okay.
Okay. Yeah. Greetings from Shalby Hospital, Orthoplasty and Special Trauma Unit. Thank you for asking me to speak on a very difficult topic. I may not be well versatile with the newer modalities. Please excuse me for some of my ignorance. So I think that's what it is. The incidents, and again, thankful to Rajesh because he has already covered a little bit of basic principles. Anyway, the incidence is about 0.4 to 3.5 and is a rough figure because really we do not know. And is the third most common reason for revision. Patients are outlawing their implants. Number of primary and revisions are increasing. There are multiple systemic and local risk factors are. I think this is the classification, Duncan's classification, which provides a friendly algorithm to guide the management regarding the fracture location, stem stability, and quality of remaining bone. This is the main principle on this classification. And I was lucky that we had met Duncan personally in Chennai, and Dr. invited him in one of the meeting, and we were lucky to discuss this classification with him. I think this classification mainly is started with A, B, C. A is a trochanteric, that is a greater trochanter, and AL is a lesser trochanter. P is around the stem, that is the most important most important thing. B1 is a stable prosthesis, B2 is unstable, and third, B3 is a very inadequate bone stock. There's a very poor. C is well below the tip. And now today, this is unified classification, which has recently come as a Duncan and R classification. And that's a new, the additional classification to A, B, C. The D is a fracture of the diaphysis, either distal metaphysis of the femur between the hip and knee implant. And that you know that number of now surgeries are hip and knee also are increasing. E is a fracture, both femur and pelvis following the replacement. And something new which has come, F, I really don't know what this classification is. What is the initial assessment of these patients are? Identify ongoing symptoms, thigh pain and groin pain, which we are really missing. We rule out infection. The rate of infection in this group of patients are very high. Radiology, location of the fracture, stability, type of the implant, integrity of the cement, we are not able to identify. Previous radiographs are very helpful. Unfortunately, they may not be available for many times. CT may add value, especially on the established side. And very important is intraoperative. How do you know the stability of the implant? A direct method, the B1 fracture, we don't dislocate the hip. And if there is any doubt, you should dislocate the hip and see the implant stability. Second important is the indirect method. That is, distal stem can be translated for the mobility, and that can give an idea. But there is a discrepancy of 20% between the preoperative impression of the implant and intraoperative finding has been well reported by a few articles. The fluoroscopy screening in the operating is very questionable. How the success can be with a less invasive, what the Rakesh was telling, that we should have a MIPO approach and keep the soft tissue fairly intact. This is something new, which is a balanced plate construct, which is very important, and composite implant solution, appropriate reduction, axis, rotation, length maintenance, all that is important for getting a good success. All these injuries are very low, we are missing them. And this is something which is B1 is only 29%, very common, more than 50% are B2, which are unstable implant, and B3 are very small. Something like my boss used to tell always that the crow is sitting on the tree and the tree falls down, and we all blame crow, and it is not that, it is actually the orthoplasty should be blamed, because there is a lot of osteolysis and loosening of the implant, and that is what important is. So something, now the greater trochanter fracture, that is called AG, no clear guideline for the treatment of this migration. Usually they are limited displacement due to the soft tissue because the sleeve is intact. Biomechanical studies have shown 15 to 20 millimeter migration may hamper longevity, but we really do not have enough data on this. So this is one example from our own unit, Dr. Dholaka. In 1977, he operated. That time we used to do a transtrochanteric approach, and that was the non-Indian, but less than 15 millimeter. Look at this, 45 years of follow-up. Only last month he had a revision on one side, and he waiting for the opposite side revision. So this is a trochanter non-Indian. We really don't know regarding the longevity of this implant. These The osteolysis is the greatest phenomena which happens, and this is one of a patient who had osteolysis, and I revised. I just put a liner exchange, got on highly cross-linked poly, and just this trochanter needs to be fixed really prophylactically, and some medial grafting was done. This is a 10 years follow-up of this lady, and this is one of the common thing which is important. This is something I was not knowing maybe at 25 years or 30 years back. And this lady had a monoblock cup. Many people would not have seen this. This is a moisture cup, which is an all poly cup. And I had no choice to replace that at that time, 25 years back. And this was a trochanteric osteolysis this lady had. And I had to get a hook plate prepared locally at that time. And this is almost about more than 25 years back. And at that time, bone bank was not there. I used the IAA crest graft for this lady. And she came for revision in 2014 to this hospital, and I revised it, but keep the plate there itself. I just took out a couple of screws and put them back again. So lesser trochanter fracture, most of the time they're ignored. They're isolated, like it should be ignored. But very important message for all of us is, if it involves on the medial calcar, it has lost its stability, and this is called pseudo type AL, and this needs an aggressive surgical treatment. And look at this, one of the examples from our own unit. Cemented hip was done by one of my colleagues, and this within just about 10 or 15 days, he missed the medial calcar fracture, and this has to be revised to a longer stem and get some cables on the proximal side. So this is one very important message. If there is a large fragment on the posterior medial side, this implant is unstable. So what about the around the prosthesis? B1 is a stable with a fixation, but we recommend during the earlier time also we recommend the bone grafting, which I'll tell you why. And B2 were unstable, and they had to be revised. And B3 are completely the bone is unstable and with a complete loss of proximal bone, and they either revise or substitute. So type B1 fracture around the body, prosthesis is well stable. If you look at this picture way back in 80s, that you will there are no radiolucent line, no osteolysis at that time, and this was just a DCB plate at that time because we didn't have a locking plate during that about 25-30 years back. And but the medial bone grafting was done from the iliac crest, and that fracture healed very well because there is an endosteal blood supply is lost, and you have additional periosteal blood supply, and that is the reason it requires a medial bone grafting for this. Luckily, now we have bone banks all around, so this is a possibility now. This is again about 40 years back. This hip was done by my boss, and he had osteolysis on the cup side, so I revised the cup maybe about 12 years, 14 years back, and this recently he had a fracture, and this was fixed with the the newer principle of locking. So very important, keeping the working length. There's a second is known as a plate span disc width, and another important is a plate screw density, which should be less than 0.5. And this is complete restoration has taken place. The cemented hips, radiolucent line on the proximal side, especially on an exeter or highly polished stem, they are not the sign of loosening. And this is a very micro subsidence where one should not worry about the loosening of the implant. And this is something uncemented implant with a interfragmentary fixation and the locking plate. What about the concern on B1 fractures? Implant stability is very difficult to ascertain unless you dislocate the hip. Prior clinical symptom and X-ray are very, very useful, and that is what important message for all of us. B2 are usually classified, and they are treated like a B1 fracture. That's why they get a poor prognosis. So the most of the time implant is unstable in these patients. And this is what the data is: 23% failure of B1 fracture because they were underdiagnosed. So today the locking plates have made a lot of difference. I don't want to go into detail because this will be covered in this. This is one example of just a trochanteric fracture. One of my colleagues fixed it, and unfortunately there was a stress riser at the level of the tip of the implant, and he developed a B2 fracture. Implant was stable, and what he did a good job. Actually, one of our unit only good job, and And this was a fixation with a locking plate. Unfortunately, this failed. So he requested me to come in and again do this. And what I decided to put the fibula graft, the stud graft. I did a refixation. I get the fibula stud graft, and you look at this has united. So this is one of the indication of getting stud graft for this patient, either failed B1 fractures. Very important. What about B2 fracture? I think they are loose stems, and they require, there's no question that they require a revision and revision. This is one of the patients which we did at a long time, maybe 25 years back. That time we did not have anything, but with a cemented stem. But look at the cementing done beautifully, and he had a good follow-up of this patient. And this is important for radiolucent line. If there's a global radiolucent line, you can't keep this implant. You need to take it out. And this is something which I did. And this is a 10-year follow-up of this gentleman. Unfortunately, the COVID, we lost last year. We lost him. This lady had a hybrid hip, and she was waiting. She's a rheumatoid. She was waiting for a hip replacement, the revision, and she landed in the hospital and had a fall, and she had periprosthetic fracture. And I did something like this with a fully coated stem and some got a cable. And I thought I had done a fantastic job, but look at that. So she had a non-Indian. I would have done a medial grafting for this patient, stud graft. And second important thing, otherwise I would have put actually lateral plate supporting, which I did not do it, and learned experience from this lady. And she had a non-Indian at that. I even did I gave a course of teripeptide, did not work. And she landed with a non-Indian. So I'm very thankful to Ganga Hospital at that time, 10, 12 years back. I got a graft. And I'm thankful to Suri also to give me the theater at the Chennai, because the transport was a big problem at that time. I couldn't transport this to Ahmedabad. So this was the done, and this is a 12 years follow-up of this lady. So these were cadaveric graft. So what about concern on B2 fracture? Usually managed by a long stem along with the supplement, but the supplement is needed. The only internal fixation had a very high rate of failure, that is Swedish data. But there is a recent meta-analysis, maybe due to the newer implant, newer fixations. The recent meta-analysis B2 and B3 were compared with the fixation and revision in elderly low demand patients, and it looks to be beneficial, but it is a very, very small subset of patients. But they recommend anabolic supplement are recommended for these B2 and B3 fractures if you try and fix them. What about the B3? That they are loose, there is a poor bone stock. The options are you have to revision stem, proximal femoral replacement, allograft. Unfortunately, we don't have. Impaction also, we are not been very in the favor, but I think the experience centers have got some results. The choice of implant are uncemented, modular, taper, fluted. There is no doubt about it. I think fully coated stem are completely getting out. But overall complication and B3 fractures are extremely high. Rate of dislocation, infection, and so many other factors are. So this is one example of there are 6 times operated this lady. There's nothing like a proximal bone. So what I decided to do a proximal segment, LPS, LCPS. She also had a knee replacement, knee replacement. This is something unusual I saw about 10 years back. And this was an implant was totally the outside, and there was nothing in the proximal bone. What I decided to get a distal fixation will fully, and I did a little medial reconstruction with, luckily we have a bone bank. I put some stud grafts, I put some tibia grafts, and look at the 10 years follow-up. This lady survived extremely well, and some bone has formed, and she was walking around. Unfortunately, 2020, she had a fracture of the distal tip at the level of the tip. Unfortunately, we have lost her because of the, again, COVID. So what about the type now, the newer classification, type D, that is the interprosthetic between the total hip and total knee. This is one such patient. Very important now, this what the system is now. Use block analysis method. Look at the only hip and see what it is. And then you treat the hip according to the principle, what we described is the location, implant stability, and quality of bone. And then look at the knee and they separately. So separate, we have to do this and do the analysis in as a separately. And that is called as block out analysis method. And this lady we did a dual fixation, and this united extremely well. So that what is for the interprosthetic. What about the type E? I didn't had an example, but this is some on the block. Again, you have to use a block method principle. Look at the acetabular side, look at the femur side. This is the lady rheumatoid who had a acetabular, the whole thing had gone in, and there was a pelvic rotation. That's a very important on the X-ray to identify, and something like a pelvic dissociation, which at that time we had to, maybe I this done about 18 years back. I done this, and you see the look at the bone which is reformed. So the algorithm type A is that I discussed already. The medial cortex, if there is a medial cortex has gone on the calcar side, you treat it surgically rather than waiting for something else. And any migration more than 15 millimeter, I think I am the favor of trochanteric fixation. Type B, which is very important, which we discuss the internal fixation and cortical strut graft, depending on the stability with the implant. B2, long stem revision, definitely requires some grafting area. B3, either you do a long stem or you augment or proximal femoral replacement. We have no choice of getting allografts as far as today's concerned. Type C is a disregard implant and treat according to any fracture. Type D is interprosthetic blockout, and type E is also the same on but the fracture of the acetabulum as well as the femur. So again, you use a blockout system. So what are the limitation of this classification is? Lack of clinical data is incorporated, lack of previous images, because that gives an idea of the implant's situation of the whether there's a fibrous ingrowth or whether the loose or the cement. What about the cement metal? What implant stability? No fixed criteria has been described. Lesser trochanter with medial calcar, we have to be very cautious, not been very clearly identified. Criteria for rotatory fixation has not been very crystal clear. Failure of B1 fracture are due to underdiagnosis. No specific criteria on the implant has been described in this classification. I thank you for attention. Thank you.
Thank you, Dr. Pachore. I think that was the whole run through the history of THR almost. Thank you very much. I think we'll take question and answer after Vijay's talk. So Vijay, let's put some sense into this classification.
Yeah, right. Thanks, Rakesh. Thanks to Rajiv and everyone to. Can you see my slides?
Yes.
Yeah, it's clear.
Yeah, so good evening again. So I'll be talking on the approach to periprosthetic fractures, and especially we will look at the biomechanical considerations. That's very important. And what I really want to do, why I put this 2022 is it's all right, showing cases of this did periprosthetic fracture, etc. But what really the junior surgeon wants to know is what is in and what is out. What should we be doing in 2022? So I never get tired of telling this in recent times to my juniors that we must now understand that arthroplasty is a mature technology, just like electric cars. So the mature technology means almost every one of your arthroplasty procedures must be successful. And that's a very key point. If you take electric cars 7-8 years ago, if you had one successful car, it was news. But so we were all showing X-rays of stray cases. I did this, I did that. It was all okay a few years ago, but now it's not. Now it's a mature technology. And therefore, every one of your case or almost close to 100% must be successful. And that's what all the, what you must employ in arthroplasty. So in a mature technology, success is not news, failure is news. And that's the cardinal difference between the two. So all your concepts and algorithms, because of mature technology, must be crystal clear. And hopefully this talk would make these concepts crystal clear. So this is a common diagram that's used in many talks that, you have Dr. Pachore has gone through the classification, Vancouver classification, that, with type A fractures, conservative, B1 is internal fixation, B2 is revision, and B3 is a long-term revision or allograft, and type C is independent, you can treat it independently. So is there all there is to management of periprosthetic fractures? No, actually. There are a lot of caveats, concepts, and common mistakes which I'll highlight during the course of this talk. So type A is the great trochanteric fracture, as we know. The recommendation is to be treated conservatively. However, you must be careful that if you have displacement of the great trochanter more than a centimeter, then you must it will cause instability of the hip. So it's best that you fix that. That's a very important concept, that not all great trochanteric fractures can be treated conservatively, but most can be treated conservatively. And what option to use? You can use either a wiring, a tension band, or trochanteric plate, whichever is comfortable for you. But the more interesting is the lesser trochanteric fracture. And there's again, the recommendation is be conservatively based on the Vancouver classification, but that's just not true. Dr. Pachari also covered this. Remember that avulsion fractures of the lesser trochanter occur only in children and part of sports injury. It never occurs in adults, especially the joint replacement population. So fractures with the lesser trochanter or type A fractures only in the background of osteolysis. Somebody's got osteolysis, yes, you can have isolated lesser trochanter. Otherwise, it is never a type A fracture. It's always a type B fracture, and you need to treat that. So this is the common fracture that we see. This actually is an intraoperative fracture, which manifests, a few weeks down the line when the patient starts weight bearing fully. This is typically a medial side fracture with the calcar and with the lesser trochanter at the middle of the fractured fragment. It's a classical intraoperative fracture that manifests late, slightly late, and you must not treat as a lesser trochanteric fracture and treat conservatively. It needs, here is a classical one, which you are treated with a revision surgery. Yeah. So this is a very important to identify, and the implant will be unstable, and this must not be treated conservatively. Neither should be fixed, because if you use a taper stem, the implant is unstable and it needs a proper revision. Now we move on to B1. The recommendation based on the Vancouver is the internal fixation. However, there is a caveat here. Mistaking type B2 for B1 is the commonest mistake made in the management of periprosthetic fracture. The Pachari also did highlight that commonest mistake. So in a periprosthetic situation, it's a very important concept that an implant must be assumed to be loose unless proven to be stable. It's not the other way around. Any implant in a periprosthetic is loose, and you have to prove it's stable, not the other way around. And in spite of all the investigations and CT scans that you do, the final categorization of B1 has to be intraoperative. It's an intraoperative finding and not based on any investigation that you do. Now, apart from assessing whether an implant is loose or not, there may be other factors like surgical errors, biomechanically unfavorable bone, weak or pathological bone, or infection. So all these will also determine whether this should be fixed or you must opt for revision arthroplasty. So it's just not whether the implant is stable or not. If it is biomechanically unstable from day one, biomechanically unfavorable, then it may not be a great idea to salvage that with fixation. Here's a classic article by Henrik Malchow, and this is where he said that the difficulty in separating B1 from B2 suggests that the process should be considered as loose unless proven. So this was a classical statement. I think every junior surgeon must take, the take-home message that when you deal with periprosthetic fracture, the implant is loose unless you prove it to be stable. So very important take-home point that you have. So another very important point in B1 fractures is that when you have a stem, only the composite beam stems can never be B1. A very important point. So only a taper slip stems can be B1 fixation. So some example here is a taper slip stem that has been elegantly managed with fixation. And what you're really doing here is you're not actually plating the bone, but you're plating the cement mantle. So it works very well in taper slip stems. However, when you have a composite beam, this does not work at all. So that is the, you can see this is a composite beam stem. You can see that. And somebody has tried to fix it. It's like a Charnley type. It's a composite beam. The rough surface. So the implant and the cement is one unit. And therefore, the chance of failure, you may show occasional success, but the chance of failure is very high. Even if the fracture unites, the implant will become loose. So you must not try and salvage these fractures. So this has to be revised into revision arthroplasty, because the chance of success when you plate a composite beam periprosthetic fracture is very poor. So another important take-home message that the plating is allowed only when you have a taper slip stem like the Exeter or the C stem, and when you have a Charnley type prosthesis, when it's a composite beam, it means that actually periprosthetic means is equivalent of a stem fracture, So you must try not to salvage it. I must move over to a proper revision arthroplasty. So here you can see that composite beam stem. It's here, and some surgeon has attempted to. It just shows it, that you should not be doing, and the surgeon has attempted to fix it, and you know what's going to happen. That's exactly what happened. It failed, and then we revised it into a proper revision. So you know that when you have a composite beam stem, that that's not going to work. Even if the fracture unites, the stem will become loose. So very important message that this fixation is true for simulated stem only when it is a taper stem and does not work for composite beam stems like the Charnley or similar stems. Now here is one that has been done correctly. So what is done, ideal principles have been followed. You can see that we have done a locking plate. It has some kind of expansion proximally. You must get at least unicortical screws. You must use cables proximally, and you must distribute your screws distally. These are the principles which are very, very critical for not advancing. I can see that. That's it. So these are the principles of fixation of a B1 type. You must use a locking plate. Otherwise, 2022 not acceptable to use any kind of plate. The expanded proximal portion, either you can use a hook plate or you can use a distal femur plate proximally, but you must have an expanded portion to get more screws inside. You must span the plate till the tip of the trochanter. Very important. You must not fail short. You can see this. One of the examples that we had was it has been fixed with a plate that is not expanded in the top. The great trochanter has not been included. It's been revised to a proper fixation with all these principles, and it's worked very well. So it clear the cement at the interface, and Pachure said you can add bone grafts. You spread the screws distally to prevent stress riser before the process. So if you follow these principles, it's mature technology now, and you find that you get success in almost every case. But respecting these principles are absolutely critical. So the proximally, distally, of course, we use bicortical screws. That's a no-brainer. But proximally, what do you use? That's the question. Now, cables resist bending loads. However, cables are very poor against torsion. Therefore, you must use unicortical screws. So the best combination would be a combination of both cables or wires with unicortical screws. So that in 2022, proximally, when you have a periprosthetic fracture, you must use both unicortical screws. Of course, if you can use bicortical screws, that's fine, but also with cables. So there has been some concern that whether if you put screws, it will disturb the cement mantle. But there's no, although there have been experimental studies to say it can disturb, but there's no clinical evidence to say that the screws will disturb the cement mantle and you can use it very, very safely. Oops. So these are the 4 methods that you can use. Distally, of course, we use bicortical screws. That's thing. Proximally, whether you use only cables or only screws, both are not as biomechanically good as the type 4 one. You can see that the best load bearing capacity would be when you use both screws as well as cables on the same concept, distally bicortical. So this is the standard of care when you do on 2022. When you do a periprosthetic fracture, you must follow all these principles strictly. And then you'll find that that the success is not news anymore. Only failure is news. So we go move on to B1. So example of B1 correctly done, exactly the same hook plate, distributed screws, expanded, everything has been done. So in some special situations, you may violate these rules. Here's a patient of Paget disease, which I had. You can see I could not put an intramedullary stem distally, therefore no other choice, although not the ideal situation, pathological bone. So we managed to fix it and did gone. So this is a rare case in which you can. I just mentioned the paraskeletal clamp just to ensure that nobody uses this today. That we used to use it earlier, the Mennen clamp, but this is not to be used. It's got very poor biomechanical properties, and this should never ever be used today. So just to mention that, I put this slide. So we move on to a B2 fracture where the obviously the implant is unstable, and here you can see an example of how we have fixed that with the distal fitting process. Now the important principle here is just like the B1 fracture, there are very important principles that you take home. You must try and achieve scratch fit distally for required length. You must have adequate canal fill. You must be careful about distal cortical contact. And the stem diameter must be on the larger side. It must be monoblock. Now we all have examples in which we have used modular stems. We have used cobalt chrome stems, and there have been occasional success, but your failure rate will be very high. Now, what is the important concept in this is that you must eliminate the race. Now, if we don't follow these principles, for example, if we use a solution stem, a cobalt chrome stem, some of it may be successful, but there's always a race between bone healing, fracture healing, and your implant breakage. So some cases will be successful, some will not be. But if you follow these principles, there is the proximal fracture need not unite. I want to make it very clear that you're not depending on the proximal fracture union for long-term success. Even if the fracture does not unite, nothing will happen. And that's a very, very important point in 2022, that you must use only this type of implants. And just to make the point, here is a patient whom we have used this implant for a bone tumor case without any proximal bone support at all. So you don't actually rely on the proximal bone joining for long-term success. So you take the race out of the equation. It's not a race between the bone, the periprosthetic fracture joining and the implant. So you have to eliminate the race today so that you have success in almost all cases. So very important point. So what should not be done? What should not be done is this something like an SROM. Again, when you use an SROM, it becomes a race. Sometimes you may be successful, sometimes you may not. But here's a case in which the SROM has failed. Substance has occurred before the whole the periprosthetic fracture joint. So this had to be revised. So the point is, you must use only a titanium monoblock stem so that the race is eliminated. No more a race. So you'll get success in almost all cases. So again, here you can see a cobalt chrome stem, and then you can see that breaks. If it is proximally loaded, if the fracture doesn't join, then it will break at some point. So there's a race between the implant and the fracture. And at one point, if the fracture does not join, the implant will break. So the modern concept is to eliminate its race. That's a very important point that has to be highlighted. So these are the principles. You must have this good canal fill. That's very important. So it must be at least 150 out of 200 in your C-arm X-rays on your. So all these principles are followed. Then there's no need for having any proximal bone. It still works very well. So here's an example in which I use unnecessarily a long stem, and you can find a periprosthetic fracture, and you can see that has caused a tip fracture. So you must not go too long. That's another concept, that if you go too long in these stems, monoblock stems, because of the bowing of the bone, you may have a fracture. So you must be of adequate length, and you must have adequate canal fill, and you must have a scratch fit. So this one has been employed correctly. You can see that all principles have been followed. Now, whether this fracture unites or doesn't unite is really only of academic value. It doesn't matter for the patient. Still, the thing will function very well. Another example of that, principles have been followed correctly, correct fixation, not too long a stem, a monoblock titanium stem, and everything will work very well. So you can almost ensure that in all cases you'll get success. Now we move to B3, where there's very poor bone stock, and Dr. Pachuri talked about this. Allograft, again, principles are involved. You must have two hemispheres, contograft to match the outer femur, minimum 10 centimeter long, at right angles to each other. You must autograft at the junction. Fixation is with cables. So all these principles are important. And if you have a B3 fracture, you can we can put a stud allograft, provided it is available. These days we find difficult to get these stud allografts, so we almost never do that. Now type C is fracture much below. So here's a patient of ours. You can see that fracture is an articular fracture. So again, these principles are very important. Essentially, articular fractures like this are fixed with locking plates, and very important, locking plate must go all the way to the femur, and at least the distal half of the implant must be covered, not just one screw, but the distal half must be covered. Essential shaft fractures, which are shaft fractures, are best treated with a combination of a nail and a plate. I'll show you examples of that. A plate must always overlap the stem to prevent stress riser to a significant extent, and spread the screws distally so that you have no stress riser. So all these principles are extremely important. You can see how we have used all these principles, and if you use all these principles, you'll find that again that you'll have a very high success rate. Now you can see this one. This is not a articular fracture; it's a non-articular fracture. If you have a non-articular fracture, you must use a nail as well. You can see how we have followed the principles. We have used the nail as well as a plate. And for these non-articular fractures, you must add a nail to the for consistent success. Now type C, again, what should not be done is, you can see this inadequate fixation has been done. You can see just one screw beyond the tip of the stem, inadequate, no spread of screws, and this will fail. You can almost be sure that it will fail. Okay. Now this is Pachuri talked about it. This is the new classification, the interprosthetic fracture, type D now actually. And then again, it's very important that you follow the principles. You have to overlap the stem to a significant section, and you must cover both the implants. And if necessary, you add additional plates to increase the biomechanical stability of the construct. So one word about adjuncts. Adjuncts, I think, are also very important today. So you have autograft, if available from the iliac crest, great. Fibular graft, rare, but can be used. Teriparatide we use in all cases of periprosthetic fractures. We use teriparatide. And if a patient can afford, we also use BMP, which is found to be extremely useful as well. So these adjuncts are also will increase your rate of success. So in conclusion, it's a challenging problem on the rise. However, if your principles are and your algorithms crystal clear, the chance of success is very, very, very high. It's close to 100% now. That's the thing of a mature technology. So I thank you for your attention. Thanks very much.
Thank you, Vijay. I think it's a very, very well presented, Dr. Pachauri and Dr. Vijay. Now the questions from the house. Vijay, what will be your choice of fixation for a B2 fracture with a cemented prosthesis? If there is a cemented stem earlier, what will be your choice for revision?
Choice for revision, other. You mean using a revision stem?
Yeah. Will you use a cemented one or a cementless?
No, always cementless.
Yeah.
Because another important point which I didn't mention was, if you're going to use a cemented process for a periprosthetic fracture, you must do impaction bone grafting. You must never do a periprosthetic fracture with a cemented stem without impaction bone grafting. That's a fundamental rule. So as I said, it's not just using a non-cemented implant, but you must use a titanium implant. You must use a monoblock implant. All these are important because if you use any other kind of implant, the chance of success comes down quite significantly. For example, if it's a modular implant and the fracture does not unite, the junction will break. If it's a cobalt implant, if the fracture doesn't unite, the race, and if the fracture doesn't unite, your implant will break. So we have to use for a periprosthetic fracture only a monoblock stem, a titanium stem, and follow all the principles that are highlighted. Then you will not have those failures.
Right.
Vijay, I'll just put one question to you.
Yes.
The principles are all fine if you have a very fit and good patient. Most of these patients are reasonably unfit, I would say, and they have actually come across after they have had a fracture, lying in bed for about 4 or 5 days, sometimes even longer. So I'll just put the same question what Rajiv was asking. Let's say you get a cemented stem which has now fractured, not the stem, but the mantle is fractured. You've taken the stem out. The stem is loose. Now what would you do? Would you take all the mantle out, or would you bail out and actually do a longer cemented stem using the same cement mantle as an additional one? Now here we're talking about an unfit patient because this is a very common combination we get.
Yeah, I take where you're coming from. So very elderly unfit in the ICU patients, we do fix those fractures and try and cement it. But that again is a compromise situation. So if I find that the patient will take a revision surgery, I would certainly go ahead, get distal fixation and be done with it. But if you do a fixation, especially for a composite beam stem, you are looking at loosening of the implant down the line. So you need to have another surgery down the line. So if you have a composite beam stem, I would do a revision surgery with a distal fitting non-cemented stem. That's the way to do it.
So any more questions from audience for Vijay or Dr. Pachauri? Otherwise, I'll have more questions.
For the benefit of the audience, I'll ask you one more thing. Your preference between the cable and the steel wires. Which one and why?
So as I highlighted, other controversies have all been resolved except for this controversy. Some people think cables is better. Some people still think that wire. So we personally are going to use only wires. We think it's equally good and does not strangulate the bone. But there are equally good results from other centers where they say the cables also work very well. So that's one, in 2022, there's one controversy which is yet to be resolved. Only down the line, we'll know which is a better option. But we personally use only wires.
Yeah, my feeling is that the cables get slip easily and the cost also. If you use a good quality steel wire, I think that is a preferable one.
So Rajiv, that's a very good thing, that good quality and also new one. The problem with the cable, the wires is that we actually take run-of-the-mill, the wires which have been used for, let's say, tension band wiring patla. And it's the same autoclave wire which comes out, which has gone repeatedly into autoclave. So I think if we know that we are going in for a fracture, we should get new sets of wire and autoclave them purely for this purpose. So then I think we are okay with wires. That's the only advantage I find with cables, that we know it's a secluded one, only been sterilized for this very purpose.
Right.
The other advantage I think you can get with, we don't have them very well in India, is you can get tensionometers with the cables, which you don't get with wires. So if you know how much tension you can actually apply when you're putting it onto the, because these are osteoporotic bones and they can actually dig inside sometimes.
I can just give one small tip on this, that when you see that there is a secondary bend is happening, when you are tightening when you're using the AO tensioner for the wire, the moment you see that there is a secondary bend is happening, now that is the point where more you tighten, the wire may break.
Okay.
One
Shubhranshu's
important
got some-
point.
Dr.
Yeah,
Pachore, your suggestion on this, sir?
because one important point regarding the cable, why it breaks. So whether you have to look at whether you are tightening it clockwise or anti-clockwise. When you're using anti-clockwise, then when you are bending that cable towards right side, then it becomes loose. And when you are bending it clockwise, and when you are bending it towards towards downside, it is good. But if you're bending towards the opposite side or upper side, then it becomes loose again. So that is the commonest mistake which people do. It should be bent either perpendicular to the plane of the cable. It should not be bent along the cable. If I don't know whether I have explained it properly or not. Because
we're talking about cables or wires?
Cable wires, I'm sorry.
Wires, okay, yeah. Because
wires
cables
when
you
you're
actually
bending.
have trims. You don't.
So whenever bending
bend them.
along the line of the cables, then one side there is an acute angle, and because of that acute angle, there is the cable breaks there. So it has to be bent perpendicular to the line of the cable. And one more important point is in especially osteoporotic bones, when you use these cables, when you tighten it properly, then the bone, it cuts through the bone. It becomes difficult, it doesn't hold the bone. So one has to be careful that in osteoporotic bone, it's better to use wires rather than the cables.
Right. Rakesh, I think we can start the cases now.
Yeah, so I think I request Dr. Sunit Hazra to start
Yes,
his case.
Yeah.
I think we'll probably have some more points coming up with each case.
Yes.
Yeah. Thank you, Indian Arthroplasty Association and Rajput sir for giving me the opportunity. But I think every point is almost covered, and my case is relatively very simple, V1 type of fracture. But I think what we had as this patient had a 74-year male, so he had a acetabular fracture about 20 years before, and then he started lived 20 years with some pain, and is now ready for the hip arthroplasty because of this pain. And this is the CT scan showing a blood acetabulum are quite proximally migrated acetabulum. As you can see that the real acetabulum is quite low, and as you can see the mark by my suction cannula, and the false acetabulum is also quite sclerotic and quite big. So what we did actually, this is the true acetabulum and the false acetabulum you can see, and we grafted from the head and put it screws, and the cup was quite stable at that time. This is the post-operative X-ray of that patient, immediate post-operative period, and we were quite happy that probably we did some good job with this patient to bring back the center of the rotation of the hip and everything. But up until 3 months he was quite well with this, but at 9 months he came up with this periprosthetic fracture, and I think I classified it as a B1 as a stable fracture, because the perioperative also it was quite good, and patient was having no signs of loosening around the implant in the proximal segment as well. So this is the close-up view, and this is what we did actually, the plating around the stable fracture with the wires and screw combination and distal fragment as well. But the obliquity of the fracture was quite long, so I was able to get 2 or 3 interfragmentary screws as well. So I think This patient is now around, this is a 6 months follow-up of this patient, and the fracture was uniting, and now it is patient is about 1 year, 6 months down the line, but the patient is doing well. So till now, patient is doing well, and the proximal graft also looks quite absorbed. So this is the simple case. I think I don't think there is too much to discuss on this after those two lectures. So it's a simple short.
So anyone's got a couple of comments to make on this case before we move on?
Thank you, Dr. Hazra. I think it's a wonderfully done case. Especially the cup fixation was very nice. And I think the fixation choice was good for the periprosthetic fracture.
Sunil, just come back to your post-op X-ray.
Yeah.
So I think if you've listened to Dr. Pachore and Dr. Vijay Bose also, that you need to put more screws proximally and more screws distally, and in the middle probably you should try and leave as much space as possible. That way you increase the working length of your plate without actually putting too much of work. So I think that's the only thing I could probably talk about in your case. Otherwise, I think it's been reasonably well.
What about the interfragment screw? Could have been avoided?
Yeah, avoided. Yeah, better avoided. Yeah. But what you can do at times is, for reduction purpose, you can start up with an interfrag, and that will hold it. Either you can use a circulage wire or an interfrag, and then just span the whole thing. It's a biological way to go forward for these fractures. Yeah. So around the fracture, put as little screws as possible.
Okay.
Yeah, this is a very good fracture for a fixation. The distinct point about this taper stem is, that we use is the Corey stem, that if the fracture involves the proximal portion of the stem, even if it is stable, then you must consider it to be unstable. But here you can see that the fractures involve the distal portion, because these stems need to be fixed proximally. They're all proximal loading stems. So if the proximal is intact, distal can be fixed, but the reverse cannot be applied. The fracture is essentially in the proximal part, like the lesser trochanteric fracture that we, myself and Dr. Pachore described. Then the equation changes. Although the implant is stable, then they don't become proximal loading anymore. So you may have to go to a revision of it. But this is a very good fracture for fixation.
Okay.
Dr. Hazra, what was your post-operative mobilization protocol?
Yeah, I actually allowed the post-operative mobilization after 3 weeks only. So I was quite happy with the fixation, and the stay with the stem also I was quite happy. So I allowed partial weight bearing only after 3 weeks because I'm not very much experienced around the periprosthetic fracture. So I was relatively a little bit conservative side, but I think with the amount of fixation and the quality of the plate was also good. Titanium plate was there, so was reasonably stable. Could have been mobilized earlier, but I allowed only after 3 weeks only.
What are your views, Vijay, on this mobilization post fixation?
Well, I got to customize it for the case, I think. But generally, at least 6 weeks of toe touch weight bearing is our protocol that we do that. And that I think is very critical. Yeah, you need to have, and sometimes it goes on to 3 months. So anywhere between 6 weeks to 3 months.
I don't know when actually you started the two main issue. I thought even I didn't allow the full weight bearing at 3 weeks, but when I was only total, I allowed it after 3 weeks. So do you allow the total weight bearing immediately after operation?
One big issue, Suneet, in these cases is that when you tell the patient, elderly patient, that do the partial weight bearing, they usually do the full weight bearing.
Yeah.
And I think the 6 weeks time, as Vijay said, probably that remains more advisable for most common cases. Dr. Pachore, do you have any opinion on this?
One thing, Rakesh, you said long oblique fracture. Only just stabilization does not work. I think interfragmentary is a good concept. We should follow that. And we have seen, even in olden time, we had no other new implants. And we were using a DCP implant. The union rate was very good. I can show you a number of cases with about 20 years, 30 years follow-up. So I think long interfragmentary, the transverse fracture are not good for these fractures. They are the worst fractures. So one has to be extremely careful. That's why you require a long span of the implant. What even Vijay emphasized, go right up to the trochanter, up to tip of the trochanter, and use multiple fixation there. That is very important as far as this is concerned. Regarding weight bearing, I think I'm little cautious because I'm an old timer. I don't allow them, by at least for 6 weeks, I don't allow them. And most of the patients are elderly patients. They're very osteoporotic and, all other comorbidities. So I'm very careful with these patients, at least for first 6 weeks, and then get some x-rays done, special oblique x-rays to see some soft callus here and there, then partial weight bearing.
Yes, it's a wonderful discussion and presentation. Rakesh,
2
we'll move on
points.
to the next one.
Yeah, Dr. Shubhranshu, I think
Yeah.
we'll move on slowly with more complications as we complicated fractures as we go further in our presentations.
Yeah. Am I visible and audible?
Yes.
Yeah, before going to my case, there are 2 points just I want to mention. As Dr. Pachare told, transverse fractures are more notorious. When there's a transverse fracture, it is better to add a strut graft. That is number 1 point. Number 2, and in this case, that interfragmentary screws, that is a good point. Number 3, that this toe touch weight bearing, when you tell this older generation patient, they never do toe touch, they always put full weight. So in my principle, that either non-weight bearing, or if you're weight bearing, when you allow weight bearing, then tell the patient how much weight to be put, 20%, 40%. The therapist or somebody can take a weighing machine, they tell the patient to put weight on that weighing machine, see that what is 20% or 20 kilo weight, then the patient gets a feeling and then puts that weight. There are 2-3 things I wanted to tell. So I'm showing a case of periprosthetic fracture. So this is a 78 years old male, 87 kilo weight, ASA grade 2, had undergone a primary total hip replacement for whatever reason, which is not there available in the record, in November 2010. And it was a hybrid type of prosthesis. But as you can see here, there was a Duralock cup 54 size and a cemented C-stem there. In January 2020, that is almost 10 years after he had a fall and sustained this fracture. So looking at this fracture, this is the cement mantle is broken there. So it's a Vancouver type B2 fracture. That means the prosthesis is unstable, but there's a good quality of bone. If you can see the distal cortex and corticomedullary ratio, that looks like a good, quality of bone. So the next surgeon, the second surgery was done by another surgeon. He did a revision, and the cup was left intact because it was well fixed. So it is on the femoral side. They used a cobalt chrome monoblock fully coated stem. That is a solution stem, and it was an anatomical stem, bent stem, 15 millimeter in diameter and 250 centimeter in length, and with some wearing around. As you can see here, the X-ray seems to be a good fit distally, the distal cortexes, and the collar of this stem is not sitting over the calcar. That means the stem was really tight fitting probably, and that is the immediate post-operative X-ray. Any comments about this? Dr. Pachare, Rakesh?
Yeah, the 50-50 chance of success.
Yeah, what are the, besides the cobalt chrome and titanium?
One big issue, Shubhranshu, here is that the distal fixation is good. There may be a proximal osteolysis.
No, this is an immediate post-op X-ray.
Yeah,
just
no, I mean, in future, as the time goes.
Yeah.
And as you rightly mentioned, the fracture of the prosthesis, which we'll be discussing in a few minutes.
Yeah. Okay. Pachare sir, any comments on this?
So, Shubhranshu, I think if it is a fresh case which has been done, I don't think you can criticize this fixation in a lot. This seems pretty reasonable fixation. That collar doesn't always come and sit because there's a lot of bone missing actually on the calcar.
Yeah.
If you are the purist, what you can do is sometimes take one of the few bone blocks, actually put between the calcar and the collar. That's a newer thinking now happening, even with the newer designs of stems coming, that you should probably put some bone graft there. That just enhances the stability and allows a small amount of sinking which could happen. So that prevents it. But apart from that, I don't think there's a lot to criticize in this fixation.
Okay.
Shubhranshu, can we go back to pre-operative? Yeah, there is a loss of the calcar even in the pre-operative.
Yeah, yeah.
So that
Yeah,
must have
that's
been the
fine.
reason then.
But anyway, we don't depend on the, as Vijay
Right.
told, we don't depend on the proximal, fixation, or we rely on the distal fixation.
Right.
But unfortunately, 1 week post-op, patient started mobilizing and this thing happened. The hip dislocated, the prosthesis has subsided, and this is again a periprosthetic fracture. What could be the reason? There's no fall, no history of fall.
The subsidence of the prosthesis itself will make the hip unstable. And
Yeah,
while
but
subsidence
looking
has
at the
happened-
fixation,
Yeah.
15 size stem and 250 mm with a good fixation in the immediate post-operative X-ray, and this is just 1 week post-op.
There is an unrecognized fracture distally. That's the only reason how it can subside like this.
I think so. That could be a possibility.
Very right.
So
Sometimes there is an unrecognized fracture from before, and sometimes the solution itself has created a fracture which is not very well seen.
yeah, there is a possibility that. So there's a possibility of fracture migrated after mobilization which was not detected. That's why after mobilization, because patient was 87 kilo, and subsidence of the prosthesis, the offset of the prosthesis, if you can see in the pre-op, it's X-ray, offset is also seems to be less to me. And the surgeon has not used bone grafts as well. I think in all periprosthetic fracture, we recommend that you should use bone grafts, either auto or allograft or mixture of auto and allograft. So this is again Vancouver type 2 fracture and good quality of bone distally. So reported causes of subsidence include if the patient is more than 80 kilo and the femoral stem press fit distance is less than 2 centimeters. So whenever you are using a monoblock prosthesis, one need to check that the subsidence may occur in this kind of cases. So more than 2 centimeter press fit distance should be there, at least in the distal fragment. So what I did, I revised it to a modular stem. This is the third surgery the patient underwent. So when I reamed a distal canal with a 16 millimeter and put a 16 millimeter solution stem again a trial, it was easily going. So I decided to go to a modular stem. One of the things that if the distal diameter of the canal is more than 18 millimeter, then you have to go for a modular kind of stem. Monoblock stem may not be used. So because it's not available beyond that. So this modular stem, they have got sizes until about 24, 26, sometimes until about 28 millimeters also. So I reamed a distal canal. So distal part of this, I used a 19 millimeter in 190 length. Then the proximal conical part was prepared. It is used 24 millimeter, 95 millimeter, which is a high offset 45. And along with that same Dura lockup, I used a highly cross-linked polyethylene liner, marathon liner, and a 32 plus one ceramic head was used. And there's control cable plus, the wires has been used, and plus bone grafts has been used. So these 6 months down the lane, that is uniting grafts are taken up in the lateral view as well as the AP view. So just to give a message, the technique of using a modular stem is that first, after exposing the fracture site, taking out the implant, once you do a prophylactic wearing of the distal fragment, lest the fracture may migrate when you are reaming. So prophylactic wearing the first step. Next step is do a distal reaming till the axial and rotational stability. That means with the trial processes and of course with the final, that your axial and rotational stability has been obtained in the distal fragment. Next, the proximal modular component, it manages the length, offset, and the version independently of the length and diameter of the diaphyseal part. So proximal and the distal fragment, there is no relation. So you can adjust the length as well as the version and offset along the proximal part. And next you can reduce your fracture fragment and stabilize the circular cables or whatever. So these are the steps of doing a modular stem. Though earlier it was told that if the junctional part is not supported by the native bone, there are chances of fracture of this junctional part. But nowadays they have come up with the better materials, and hopefully, probably, there's not much of fracture at the junctional part. The problems with this periprosthetic fracture, there is high mortality associated with it, comparable to the primary hip fracture mortality, as discussed earlier. There are chances of dislocation, subsidence high in monoblock stems, especially the cobalt chrome stems, and there's a high reoperation rate. But if you are using a monoblock stem, remember the surgeon must take cognizance of the distal fit as well as optimizing the implant position to restore the leg length and version. So both the things has to be looked after while using a monoblock long stem. Thank you for a patient hearing.
Thank you, Shubhranshu. This one is open for discussion. Any questions for Shubhranshu? Because he's, I think, Shubhranshu, is it right to say that you would now suggest to do the modular stems instead of monoblocks?
Not in every case. When the proximal bone is not supported, you have to be a little skeptic, because earlier there are a lot of fractures at the junction of the junctional area, but nowadays they're telling it's a better and better material has come. But I find it's convenient to use a modular stem because I can have a distal proper fixation, see the axial rotational stability, then decide about the length and the version, and as well as the offset using the proximal part. But Wagner stem is a very good stem to be used in a periprosthetic fracture. But if the diameter is more than 18 millimeter, then I will go for a modular one for sure.
Okay.
So the actually Wagner real sizes go till 28. Just that it's not available in India. Not that the Wagner stops with 20 at all. Wagner goes to 28.
Okay.
So Vijay, then should we talk to the company from IAA that they should keep these sizes available?
Yeah, I've been doing my bit of
Because
it.
even I have felt at times that I have struggled. So what I've ended up doing is actually a very shorter stem and a plate, rather than actually putting a Wagner.
Yeah, that's a serious problem. Yes, we need to have bigger sizes. Absolutely, yeah, no question about it. We have run into the problem many times actually.
Okay, I think we'll move on to the next case. Dr. Clivanan, you ready? Okay.
Yeah. Can you be able to see my screen?
Yes, yes.
You can, yeah.
Yes, sir. Good evening, everyone, sir. Thanks for the opportunity. Hereby sharing the case of periprosthetic fracture. And this case one is an example of stable implant and Vancouver one. And we did a stabilization with a long plate. And to add on point is, most of the time, be ready to have even a double locking plate and medial also plating. And better to add intraoperative bone morphogenic protein, because we don't want the patient to reoperate it again. And parathyroid hormone substitute like injection Terifrac. And post-operatively, we have to go slow and steady so that we give adequate time for the fracture to heal. Otherwise, as Dr. Mohanty sir told, you will be like ending up with one more fracture or subsidence. Another one example of Vancouver B2 here is like very clear. Even then, we have to know the remaining bone which is available for the reconstruction, and better to use, be ready with the long distal fitting stems. And also, if your proximal fragments are quite big, and if you feel they are able to hold on a plate, keep the plates in advance, and the cables are SS wire as already discussed. And this one example, a 60-year-old periprosthetic fracture. He came in during the lockdown and he underwent right hip replacement in 84. And he had a cup revision in 2001 and a re-revision and a periprosthetic fracture in April 21. And the outside surgeon adequately fixed the plate with locking plate, and to the immediate post-operative X-ray was looking stable. He also added an interfragmentary screw in just below the femoral stem. And you can also see the osteolysis around the old Charnley stem and the SS wires. But intraoperatively, he felt it was quite stable, and he just added a locking plate. But the fracture eventually failed. The fixation failed. These kind of fracture fixation failure we used to see common when the cora is just below the femoral stem, when both the forces. In such cases, even though the proximal fragment looks adequately stable. And here the surgeon added a long plate, but it won't be sufficient. Either you add one more plate on the anterior aspect, just like a derotation plate, or add fibular graft, like as Dr. Pachore sir told, or better, whenever you feel the fracture is at the coral level, it's always better to increase the length of the stem and also add on to the fragment. And whenever we do revision, we don't want the patient to come back again, and have an idea of the stem head size, and what the cup size and what kind of bone is left in the acetabular socket, so that you will be able to order the implants pre-operatively. And here in this case, the fracture, we removed the proximal fragment in total, keeping the medial cortex bone and intact, and we use a long distal fitting Wagner stem, and the unitization was done so with the proximal fragment. And in the cup side, we use a dual mobility cup, so that to avoid a recurrent dislocation. And this is one more example. This patient actually this time came for a periprosthetic joint infection, but this guy 25 years back, he had a hip replacement and he had a periprosthetic fracture. In that, the proximal fragment was not didn't have much osteolysis, as it was an immediate fracture after the total hip replacement. So the surgeon used a long plate with also like with a long stem and the same cemented cup, and this worked well for 25 years. And this time he landed up with the infection following COVID, and we did a 2-stage revision. And this time we just did an ETO, removed the plate, the fracture was well healed, and this time we just used a distal fitting stem. And the take-home message is a proper pre-operative assessment and a practically useful classification is needed. And intraoperative assessment is the key point. It's always better to overtreat rather than undertreat. And we should know the zones of femur which is available with our recent publication, so that you will be able to arrange the distal fitting stem like a revision Wagner or a reef or a modular stem, and augmentation with the locking plates, cables, and SS wire is needed. And whenever we do a periprosthetic fracture, make sure the proximal fragment is like comminution and the extensor abductor will be flying. So be ready to do extensor abductor reconstruction procedures, and add constraint to prevent dislocation, such as dual mobility, constraint liners, and a hood liner also. When you deal with a repeated revision periprosthetic fracture, better to send a sample to make sure there is no evidence of any periprosthetic infection. And extra dose of antibiotic, either local vancomycin or stimulants, whenever the OT time is more than 3 hours, is recommended. Have an idea of the dead space management with proper drains and VAC. Thanks, everyone.
Thank you, Clivenand. I don't know whether it was from my side, but I really couldn't hear you very well. So I don't know what the others, so I'll let the others ask questions because I really couldn't hear very well. So any question for KK? So I think we probably don't have any questions. So you stand everybody, KK. So I think Rajiv, your case now.
I'll share the screen. Can you guys see? And can you see, Rakesh?
Yeah, I can see your screen. Yeah.
Okay, so we, after the excellent discussion on the periprosthetic fracture, the one thing that Dr. Pachore has mentioned, Dr. Vijay has mentioned, and Shubhranshu has also shown in his case, the one example of a solution stem, which is not such a good solution in today's time. Like we see here, this patient who had the fracture of the solution stem after about 9 years of surgery, and this solution stem is very well fixed and it doesn't come out easily, and there are special ways to take it out. If it is not there, then you have to remove the significant portion of the bone, as you see in this patient. And that's what today I'll try to express upon our junior colleagues here, that how to take out a well-fixed cemented stem. This patient who was walking well, but we had to do a tumor prosthesis in this patient. But today's case is this patient who had a malignant giant cell tumor, operated in the beginning as a first surgery by dynamic hip fixation. The tumor was missed. I did the removal of the tumor and block resection, followed by chemotherapy, radiotherapy, and the surgery was, as you see here, the mega prosthesis. This patient was doing well. And as you see, for about 9 years, he was doing very well. There was no problem at all. He was walking around when he had the fracture through the stem. And Rakesh, can I show here? Now, this is the point where my arrow is. Can we see that there is a small line? And this patient suddenly, when he was trying to get up from the sitting position, had a severe pain in his thigh. And then after a person who was walking well suddenly stopped walking and was limping. And that's how he came to me after 9 years of my surgery. Now here, would you like to give any comments, Rakesh, Vijay?
So I think you've got a fracture around the stem base which you have, and there's also the stem which is fractured.
Right.
So you're looking for another revision now.
Yes.
Yes, this cemented mega prosthesis, this failure mode is well described, and we have seen a few. So the answer to the solution to this problem is you must remove all this, and then you must go non-cemented distally. Still have, I think, adequate strength. So again, custom mega prosthesis, but this time it would be non-cemented.
Yeah. One of the problems that I have seen, Vijay, in my cases is that the stem, whenever I've used around 9 millimeter or 10 millimeter, now that has been giving problems. So my feeling in today's time is that if we have to use, we have to use more than 10 millimeter stem if it is a cemented stem. Yeah. I'll just move on. I'm sorry about this sound. Is the sound disturbing you guys? Okay, so we could see that there is a movement of the prosthesis. We can see that it is moving. The way to remove is that you make a small window. And then after the rest of the implant also is well fixed because it is 9 years post-operative, post-surgery. So they're better to make a long osteotomy in the covering bone and take out the implant. We can, for the first fracture, we can use the same implant. High-speed bar is a very useful tool. These are the specially made hollow mills that are, I've got it made myself, 10 millimeter inner diameter, 11, 12, 14, 15, and 16. And you keep moving it over the stem, over the cement, and keep using the enough amount of saline so that it is not causing the heat injury. And then after removing the cement is easy. And after removal of the stem, you must remove the cement, all piece of the loose cement. Use the reamers, and you should go to at least 3 or 4 millimeter size higher. And this fixation, you saw that we have added another 2 centimeter of the implant. So it is going again. And that's what you see, the fixation, the suturing. And this kind of a patient can start walking almost within next 2 days or so, because it's a cemented stem. And this stem is 14 millimeter. The earlier stem was 9 millimeter. When we see this patient at 3 months walking well, a few of the things that I'll mention here in these cases is that the stem should be at least not 9 or 10 millimeter as much possible, 14 or 15 millimeter if it is possible. The second is that the seating was not so good in the earlier surgery. The seating of this stem, also the whole implant, is very important. It has to be seated very well. Otherwise, the implant fracture and the loosening is a possibility. Thank you so much.
Rajiv, very nice case and very good message actually. Am I audible, Rajiv?
Yes, please.
So if you can just unshare. Yeah. So I think very good case regarding the message also. I was just thinking, Rajiv, is it possible to actually have a hybrid fixation in these? Because the trouble with uncemented is that you can quite likely with porotic bones, you can fracture them while trying to prepare the actual, and then you've got nothing left. So what about just having an uncemented fixation right at the junction where you were talking about and the cemented down below?
Well, in my experience, I've used only the cemented stems with the mega processes, and Vijay probably has some experience on these.
Vijay, any comments from you regarding this?
This hybrid is a good concept, and they have these highly porous ring that sits on that cut edge of the bone.
Yeah,
and that's a good one. And you also need to give some kind of rotational stability for these ones, and that's a good concept. Yeah. But generally, when you revise a cemented stem to again back to a cemented stem, the results have not been very good. Unless you do impaction bone grafting. So the general philosophy would be to go uncemented, but but the bone stock was good and you had good cementation, then that's fine.
I think we'll probably not argue with success.
About these mega processes is that they are very useful processes, because in situations like this, what we've seen in many similar situations, mega processes comes up as a big support. The stem and seating of the mega processes is very important, whether you use a hybrid or use the cemented one. And I think what Vijay mentioned is very right, that there has to be some kind of a rotational stability, which is a problem in these cases. Right.
I think one good thing which is happening all around, and I think Dr. Sen is also, I don't know whether he's joined us, he's working with what is this custom-made things now coming in. So we can actually get the way we want it made, and it is still coming cheaper than what we would be putting from the foreign processes. So that's something to think about. Though the instrumentation has to match the actual processes, that is somewhere we are still lacking. So I think we'll move on to the next case. Dr. Pachore, I'll let your case come next. I'll let Dr. Sen, if he's joined us, present his case. Dr. Sen, you want me to present your case, or you're okay?
No, I'm okay with that. I can present it.
Thank you, sir.
Yeah. So, very good evening to all. Actually, let me share the screen. Yeah. This is not a very peculiar case, because it happened I'm talking about a case which I had it way back, but just because it's a very small case, a bit of introduction which I'm putting it up. When we look for these cases, which are the periprosthetic acetabular cases, they were not there when we were doing cemented replacements, because everything was get adjusted with the cement kind of giving an option. And if you look at that incidence, this was a nil in 1762 cemented, and there were 0.4% incidence in 5,000 uncemented arthroplasties when we talk about the acetabular fractures. And then there have been various reports, iatrogenic and non-iatrogenic. So these are the two kind of these situations. And when you anatomically look at it, because as an acetabulum surgeon, you tend to see them as far as the column, wall, and this concept. So anterior wall, transverse, inferior lip, or posterior wall, they are classified in this classification pattern. And what has been said, either we are doing aggressive reaming, definitely we are getting inside. or we are using a cup with rim circumference larger than the nominal diameter. It could be more elliptical in the monoblock cup, or it could be hemispherical modular shells. So this is the kind of the incidence, much more with the elliptical cup. And size of the component, if we are oversizing by 2 millimeter for the average establishment diameters. And if they are seen during the surgery, then definitely we look for the stability of the cup. I'm talking about way back in 2006 when I was doing a BHR in a patient of ankylosing spondylitis. I mean, this was not that at that time, I had not much of the experience of doing BHR also. So it was one of those cases when the rimming done, line to line cup was defined it out, and not sure of getting, because it was a ankylosing spondylitis, a very kind of a hard bone to get in. So I had little more pressure on my mallet. And then it's just a diagrammatic representation, because I could not get his preoperative x-rays. So just to demonstrate what happened, when I was putting that cup inside it, crack appeared on the superior side of it. And definitely it was a crack. I have just, because this crack was still limited to the wall part of it, has not gone to the full column as such, but it was not a wall fracture, it was going a column fracture. The direction was like to a column. So at that stage, when I saw the crack appearing, just like when we look at the femur also, when you're putting a stem and it starts cracking, you become careful. Likewise, it happened to me that while I was putting a cup, that crack appeared. Now, because I'm tuned to do these platings over there, this thing. So what I took up a plate available with me at that time. This was a recon plate, put it over there. And after that, I went with the full cup placement at that stage. And this is exactly what I could think of did it. And this is the case which I had done over there. You can see the plate, you can see the cup. And this was in 2006. Then when the literature also says that this is the kind of the plating which is to be done if there is a discontinuity, and if it is done well, there is a very good osteointegration. And this is him after 4 years when he came back for a follow-up. I mean, I did not really followed him, but he came back after about 4 years. He was comfortable, he was walking around, and definitely it made me happy also that his this thing, he was still working well. I mean, that is a situation where I could intraoperatively diagnose it, and because it was very obvious to me. And now if you go to the literature, few slides more about that, these if happen on the medial side, they say you can add supplemental screws to get that stability. That is one perception. If it happens subsequently as a trauma to the pelvis and it is a fracture, then obviously a kind of a standard fixation is done. If the same way as we are talking about the stem size on the cup size also, if the stability is there, we can enhance that stability by adding a platen screw. But more important is whether we are able to diagnose intraoperatively or we diagnose immediately after the surgery on the check X-ray. But any doubt must be assessed by CT evaluation. Now, intraoperatively, CT cannot be there, so we are likely to miss many of them. And we are lucky that we could get over at that very moment. But if we miss it, we may not be able to see till the time patient does complaint about, and we are likely to miss in the radiology also. So what this series says that if it is stable despite the detection of fracture, you can retain the cup. But if it is not stable, definitely you'll have to take it out and revise it. So as far as the literature goes, the posterior column instability happens 67% failure rate if that instability is staying there. And non-union, if the posterior column plating is not done, missed fracture will have the highest reoperation rate. So that is the kind of the understanding we carry. And plating is mandatory for large posterior wall fragment to achieve that osteointegration. So perception which we carry is fracture needs to be identified and accordingly stabilized. And we must avoid the propagation, the maintenance of component alignment stability, and that way we achieve it. Thank you.
Very, very well shown case, sir.
Thank
you. This kind of a implant, especially the BHR cup.
Yes.
Those of us who have used in large numbers, we know, Vijay will agree with me that BHR cup is very rigid cup, and but it's an excellent fixation. So in a BHR, the kind of the cup that you are using, probably the treatment can also depend upon that. because if it's a BHR cup, probably you can get away from many issues. If you are using any other cup, say for example ASR or any other cup, probably it will be a problem.
Yes. I mean, that way, they basically looking at it that the diagnosis, I could see it out, feel just like when you put a stem and if it's likely to crack, you tend to realize it and then you are careful at that very stage. So I was lucky enough to have recognized at that point.
Very rightly mentioned, yes. Yeah.
Sir, I have a question for you, sir, because
Please.
your topic was on the acetabular fractures. We've got the message that posterior wall, I think we have to fix. Anterior wall, probably we can ignore. So what about the central? Suppose this happens to young surgeons, and there are some young surgeons listening to our webinar. You start reaming, and the first reaming goes right inside the acetabulum, so central wall defect. So at this stage, then many people think if I've got a peripheral fit, I'm okay. So what's your message about this? Should we try and build this and reconstruct the wall, or I will be happy with a peripheral fit if you're doing an uncemented?
I think the concept right now is if we have got adequate peripheral stability, probably the central purchase may not be really needed. And we had some cases also where the patients came late and they had already kind of some cage put in there because it has migrated inside along with the reamer. So probably in those cases, you definitely need a medial support also, and on which you have to put a cup. But just like we do cortaloplasty also, you tend to shift an appropriate size and appropriate positioning of the cup so that it gets a reasonable amount of a purchase across it. And I personally feel about a centimeter of purchase all around, if we are able to get it up, that they are reasonably stable.
Vijay, any point on this one? This is not very common, but it does happen to people.
No, the maximum diameters of the equator of the cup. So if the cup has to migrate medially, then some portion of the circumference has to be violated. You cannot just selectively take the cup medially, like a fracture, like a femoral head can impact the medial wall, but acetabular cup cannot impact the medial wall alone because it doesn't work that way. So that is one. So you must suspect some other associated fracture along with it. It's not just the medial wall, but as Professor Sen said, medial walls have no consequence. In protrusio, in many cases, we leave the cup proud only with a circumferential fit. And as long as you get a good stable fixation, the medial wall will reform itself. We don't have to do that. But that only medial wall, if surgeon feels that he just perforated the medial wall, it's very unlikely he did that. You can do it to the reamer, but you can't do it to the cup. And he has to find out some other associated fracture is there.
So the point given by Dr. Sen is that 1 centimeter wall, if it is intact, you can use the peripherally fitting cup. That's a very important point. Dr. Pachore, you have any comment on this?
I agree with you. Unless your reamer goes on the medial side, then only you will get a perforation on the medial. Otherwise, you cannot just get the medial wall fracture.
No, that is right. The point was fixing the cup. If you have the peripheral wall about 1 centimeter size, that usually is enough to fix a peripherally fitting cup.
If you have got 360 peripheral fit, is no problem at all.
Yes.
And, because today we have a better cups with a high profile, and the porosity is much better than what we had. I think the rate of bone ingrowth is much better, much better.
So one practical point there is, if you encounter a situation like that, then you find that there's a minimum toggle in one plane. The toggle occurs only in one plane. You can be successful by putting screws, a lot of screws, and you may be successful. But the toggle occurs in more than one plane, then you got to do something more than just putting screws. The screws are not going to help you. You need to do something more than that.
Right.
You need to put a plate, for example, or you need to put an augment. Whatever you need to do, you need to do.
Yes. And the choice of the cup also should be not just the normal acetabular cup, but something with a more abrasive surface.
The highly porous cup.
Yeah.
Yes.
Dr. Pachore, do you want to present that repeat stem fracture case?
I think there is already this.
You've done so.
I think so.
That's okay then. I think
Because it is a
he's got
similar
a case which is
Same-
repeat fracture. I mean, the revision stem also fractured.
Yes, same hollow mill was used and the same thing.
Okay. So I think we can then let go of that. So Rajiv, we can do a closing remark for this.
Okay.
We've been well on time today, actually.
Thank you so much. I think it's a we have. Just 1 minute. Thank you so much, Rakesh. And I think that what is this was the one webinar that we are closing up almost within time, and very well discussed topics, very interesting topics. Especially Dr. Pachore's presence is very much welcome and respected. Thank you so much. For the next webinar is coming up, a very interesting webinar, which is going to be convened by Dr. Anup Dharani from Jaipur and Manoj Wadhwa from Chandigarh. And that's about the osteotomies around the knee, which is very interesting and important. We have made this program just in last half an hour itself, actually. Anup is very passionate about talking about it. And I think that next webinar will be very interesting. And we'll request all our members to participate in this. And because this will be a very new learning experience, because this subject is not so common. And lastly, I'll again insist upon our friends, the junior colleagues, to become the members of the Indian Arthroplasty Association, because this is the group which is fast growing, and we wish to involve all our junior colleagues as much possible in this association. Thank you so much. We'll be stopping this live stream now with a big thanks to all our colleagues and thanks to friends who were attending